Okay, then so we're back. Let's take a look at the basically axis in each individual tooth. Let's start by the anterior teeth, do the maxillary anterior teeth, and then the mandibular anterior teeth, and then move to the back of the mouth. Okay. So let's see. First, the maxillary anterior teeth.
Yes, let's do that. Let's start there.
All right, so basically what we're talking about with the maxillary anterior teeth, we're talking about the central lateral incisors and the canine. And the key to remember, I think, in this axis preparation, which is basically the common theme in all axis preparation, is that the axis outline follows the developmental lobes or the cusps of the teeth as they have been basically formed originally embryonically. So on a maxillary incisor, for example, you got your three mammelons and the three lobes on top and the cingulum, and you have to be aware of that so that the outline form of the tooth is basically replicated on the tooth, on the surface of the tooth, on the lingual aspect, obviously, which is where you would most of the time be accessing this tooth. That is the way to preserve the most amount of tooth structure. So you basically are coming in from the side, and this would be your axis preparation as you try to get in. You have to be careful here so that you are not leaving a part of this pulp horn behind, because this pulp horn, especially if you have a necrotic tooth, will contain bacteria as well as maybe some dead erythrocytes, which will then create staining in the tooth following the treatment, and that requires bleaching as a result of that. So that's the main thing to remember there. But also you have to remember that the axis of the tooth is this way, and yet you're accessing with your burr in this direction. So the common error that you see happen with the maxillary incisors is because of their basically the inclination, the labial inclination, and the fact that the root is back, people end up perforating buccally by going straight. So you need to have, once you find the pulp, then you need to have a course correction and go down in the lingual direction, making sure that this little bulge that is oftentimes created by the cingulum is also removed, and that will allow you to have the proper axis required for it. Your working length is always determined from your incisal point as the best and most viable place. And maxillary central incisors, most of the time, you only have one canal, so it's fairly easy. The key is just to make sure that it's completely unroofed so that you have no tissue or bacteria remaining.
Al, I like to think of it in terms of that the outline form of your preparation, your access preparation, should mimic the surface you're cutting through. This is for all teeth.
Yes.
So as you mentioned right here, more definitively, it may be certainly based on the developmental lobes, but in practicality of looking at it, as you look at that surface, keep in mind that the ultimate end result of your access, it should mimic exactly that surface, but be smaller.
Absolutely. So that is the key for incisors. And don't forget that pulps also, as a result, most of the cases that end up needing root canal therapy are either acutely inflamed due to trauma, in which case the pulp will remain the way it was prior to the need for root canal therapy, or they've been chronically inflamed, in which case there's usually dystrophic calcification going on up coronally. So the size has maybe narrowed down a little bit. So you need to keep that in mind when you're making your access preparation as well.
Two things that I think are really important is, and Ali, you kind of mentioned it, you showed it right here, this overhang, but that overhang has to be cleared along the entire mesial to distal breadth of your preparation.
Yes.
And not just a pinpoint place. The other is that the most common error that I see for a novice working with an anterior tooth is putting a round hole.
Yes.
Into this tooth.
Yeah.
And working from a round hole.
Yeah.
That is not, a round hole is not access preparation.
Yeah. Yeah, absolutely right. A round hole would be a mistake. And if you're thinking that you're preserving tooth structure but making it oval, you may be preserving a quarter of a millimeter of dentin or so here and there, but an enamel. But what you're missing is out a rim of bacteria that would be basically persisting, and that's certainly not helping anybody. So that's important to keep in mind. You're right. A kind of a heart-shaped or that kind of an oval. Triangular oval shaped is the way to go for the maxillary anterior teeth. And it's the same way with the central and the lateral. The lateral gets a little bit more oval because it's a little bit narrower. So that's the thing. And the common error is basically getting out on a buccal direction and perforating buccally. Also, you can have mesial or distal perforations if you have poor inclination, if you're not aligning yourself properly with these with the long axis of the root while you're making your axis preparation. So for mandibular incisors, on the other hand, you have, now luckily these teeth don't require root canal therapy that often, but oftentimes it's due to trauma or people who are just really, terrible at flossing and end up getting an proximal decay that gets these composites and they end up having these necrotic teeth. Or for pre-pros reasons. You see a lot of those for pre-pros reasons. It's because these teeth are so small, crown preparations oftentimes ends up involving the pulp, and sometimes you need to do endodontic therapy prophylactically prior to the placement of the crown. The key to remember is the axis preparation here is less triangular and more oval. So this one is basically one in which you have a fairly oval-shaped preparation. The key here is to remember that you once again are trying to get the pulp horn and make sure, very importantly, these teeth, the lower incisors and centrals and laterals, have about a 30% incidence of having an additional lingual canal, so that it's not only a single canal, you actually have two coming up. And unless you remove this ledge that's created by cingulum, you're not going to be able to find it. So you need to remove that little step created by the cingulum, and then you'll see that there's oftentimes a second lingual canal that is missed. And that could be found and treated by pre-curving your file and placing it into the canal on the lingual side.
How do you do that?
It just has to do with proper visualization first, obviously, which is an important thing,
right.
By having good loops and magnification, identification that there is a second canal, and you should really assume that. Now, it's very difficult to take an angled x-ray from a lower central, but it's possible. So try to do that too. Oftentimes, you will see a very broad root. That there is a second canal. Then what you would do is you would have to make sure that you've removed this area of the dentin that is covering it, so that you can have a better chance of looking at this broader area of the base, so that if there is a lingual canal, then you'll have a chance by putting a J-hooked file going down, scraping against this wall and trying to basically put it into that canal preparation.
What instrument do you use to work?
I use the Control Flex, the stiff files, size 10 would be probably the best one to use. You could also play around, depending on the calcification, with the 8 and the 15.
What burr do you use, though?
Oh, so I would use... I would try, if it ends up going pretty deep, then I would try to stay away from burrs, because that would be too aggressive. You can't see it. There's a high chance. Ultrasonic would be the key. And I think in that situation, the 14D, the E14D tip would be the right tip to use. The diamond coating allows you to, nicely just remove that. Now, these tips, by the way, have to be replaced often. They hardly ever break, though. That's the thing. I mean, these... I don't ever break them, but you need to replace them often, because as the diamond gets denuded, then it loses its efficacy in terms of cutting, and then it really is no useful. So in a situation like this, you'd have to use a new E14D, or one that hasn't been used that often, so the diamond particles are still nice and fresh, and then you scrape up and down in that area, being careful and cognizant of where the outline of the root is, and that's how you would end up finding it. Now, a key thing for axis preparation, and it's not just about this tooth or this tooth, or it applies to all teeth in the mouth, is that when you do an axis preparation, you want to use your DG16 or Explorer and basically touch and walk along and feel tactily the outline of the root at the CEJ level. Because that's what you're aiming for. And if you just base your axis preparation on the crown, you will get fooled oftentimes.
Oh, yeah.
You need to know where the root is. That's the key part. And because of the inclination, you don't know that unless you tactily get your DG16 and basically explore around the way you would be probing around the tooth. You would use, with a perio probe, you would use a DG16 Explorer and touch the root. You're sounding the root, the way you sound the bone. And you're creating a map of it, so that you can get better direction.
One of the errors that I have seen, but also I've had experience with myself, is the fact that sometimes the root is not aligned with the crown.
Yeah. Especially where there is a crown, a prosthetic crown.
Prosthetic
That's
crown
even
for sure.
worse, yeah,
but
because
we
it may
all
have been
kind
corrected.
of assume
Yeah.
that the tooth is going to look normal.
Yeah.
Or is going to be normal in its anatomy.
Yeah.
And I've seen roots and crowns natural off 3 to 4 or 5 degrees.
Yeah.
Where, that you expected it to be one place
Yeah.
and it was not there.
Absolutely. And some crowns, such as like lower premolars, for example, there is that natural inclination on the crown, which is why you get these perforations on those specific locations. Okay. Let's take a quick demo of a maxillary canine tooth that unfortunately ended up needing root canal therapy due to unknown reasons. Sometimes you get these virgin canines that end up becoming necrotic. And you wonder why. Sometimes it's due to trauma, and sometimes it's due to the fact that you get a little bit of root recession and you get the exposure of the dental tubules in that area. And then you can get a kind of a infection of the pulp through the dental tubules. That happens when these teeth are completely virgin otherwise. So let's take a look at this canine tooth that was referred for endodontic therapy. The diagnosis was necrotic. It just recently became necrotic after a bout of toothache. So the first burr I use on this is the saber cut, the 1557. Again, being an anterior tooth, I'd like to use the 57 versus the 58. Now, the key here, when you go through virgin enamel, is you don't want to just go in there and press hard. You create a ton of craze lines. You need to really gently brush back and forth in using lots of water here so that you can preserve the integrity of the enamel and not create anything. So as you saw very quickly, after we got through the enamel, we just went through the dentin in a flash, and now I'm using that E14D ultrasonic tip with water to very quickly remove that smear of cut material. This is what I was talking about when I said, you would use this in general dentistry too, because every time you cut dentin, you create that smear. The ultrasonic and water is the fastest way to remove it. So we had a little bit of the lingual aspect of the roof of the pulp chamber left here. And what it is, I used the 1557 again. I could have used the slow speed round burr as well in an upwards direction to kind of remove the roof of the pulp chamber. I'm refining it now with the E14D, at the same time removing the cut debris.
You're kind of laying it against the
Laying
surface.
it against this and going in a very oval shape, kind of just very gently. This is at about a 3 or 4 power setting on it. Look at that. And there's a little piece of coagulation necrosis as this tooth was recently become necrotic. So this is basically the access preparation very quickly on the canine. Here I'm putting now a little bit of canal clean in the root. This is the protocol that I use, a little bit of canal clean at the beginning. Now it helps me do a little bit of exploration. And I use then this opal dam material to get my secondary isolation. And this was a case that was done with ESX. And this is the final result. Of course, we don't go through the instrumentation or obturation here, but this is just the way it came out. And it shows the access preparation up on top.
And it shows the access opening being very minimal, but adequate to accomplish what you needed to do.
Yeah, exactly. This is the key, is that you need to remove enough. And that's really the idea of being minimally invasive. It doesn't mean to make things 10 times harder for yourself.
Yeah.
It means to give yourself the convenience form, but the minimal amount of convenience form necessary to do a predictable case. And this was the case for this anterior canine. All right, so let's come back and take a look at the premolars and how do we access those.
Very good.